as a standard procedure, will there be any complication? Because in one or two conditions where you have obstruction of duodenum, GJ is supposed to be not to be good. So if you do GJ, will that be sufficient? This is my first question. And regarding the last case, my second question is, the volvulus naturally the proximal part is dilated. So in a closed obstruction, the proximal colon and the ascending colon will be definitely dilated. So if you allow some part of colon to be remain inside, then you don't have to do any ileostomy and little reserve will be there. And naturally you have done at 72 years, in that case you will not do any pouch or anything also. So what if you do leave the proximal ascending colon instead of doing ileostomy?
The ascending colon could have been left behind in case of volvulus. I am answering a second question first. The ascending colon could have been left behind in the first case. That's true. But it seems that the entire colon was dilated. The entire colon was dilated and the patient was chronically constipated. Because of these reasons, because he was suffering from chronic constipation, because of these reasons, they went for an ileostomy. The entire transverse colon had undergone a rotation.
Madam, in the first case, is it required to fasten the first part of the duodenum? Is it only lateral anastomosis enough? Finally, you have done lateral anastomosis.
Why was duodenoplasty done?
Was it required?
The first part of the proximal part of the second part of duodenum was usually distended.
Just an anastomosis would have been enough? Anyhow, you have done the anastomosis later.
Yes, we did an anastomosis later. In order to the diameter of the proximal distended part of the duodenum and the distal part of the duodenum didn't correspond. For a better anastomosis, a duodenoplasty was done. It was usually dilated. That's right.
Regarding that case with the colon, ascending colon, you are telling, I would like to answer it because see, anyway he has got an obstruction. He has to need a diversion because anastomosis in emergency situation will not be good enough. So he needs a diversion and he is a 72-year-old man. So definitely he may not be fit enough for a second surgery. So as well as do a terminal ileostomy, either you can leave a part of the colon, sigmoid or rectum, and leave it as a reverse Hartmann procedure. And that ileostomy will suffice for his lifelong this thing. And but one thing for the case 3 I want to know, you did put the Foley's catheter in the cavity or was the patient came from the Foley's catheter from the original case?
The patient was put on Foley's catheter in the cavity.
So what was the result of the catheterization at that time?
Initially there was hematuria. After that there was clear urine. So we thought we were draining the bladder.
No, when there was hematuria, then you could have suspected there would be because an alcoholic and there is a history of fall. It definitely points to a trauma. So definitely, obviously, the diagnosis could have been a genitourinary tract injury, not a perforated appendix. That's what you showed in that.
Sir, one thing, sir. Normally we are in acute appendicitis. Normally we as surgeons we are tempted to open the abdomen by a gridiron incision. Suppose we open the abdomen in a gridiron incision, then we would have missed that Foley's catheter. Then what would our line of treatment would have been?
Emergency and
then we have to convert it into the.
First was definitely the incident would be enlarged. Even if it is a gridiron, it would be enlarged. That is not the question. The only thing is, when there is a catheterization, hematuria is there, definitely it points out to the GU trauma.
So say in acute appendicitis also, suppose we open in a gridiron and then.
Appendix is not that much inflamed. You saw that.
Your second case, you have done actually removed the tumor from the pancreas. In that connection, did you do pre-operative assessment of the insulin level?
No.
Do you have the facility here or no?
No. We don't have the facility.
So that could have been given some idea before also.
We have the assessment of the insulin level, and the ratio of insulin and all that.
Because blood sugar is going to low every time. And that's why that was the most fast clinical everything. Okay, I think now over the next speaker can speak. There is a proposal. We can close this session because for shortage of time and the election for the body will be there. So the further speakers will be speaking tomorrow morning.
I invite now the medical director of this institute, Dr. B. Swine, to felicitate the chairperson. This is just a reminder that the GB meeting of ARSI will be held in this hall from 5 to 5:45 PM today. Today's